Today we'll be discussing about a very interesting X-ray, and that is an acute pulmonary edema. So you can simply pause the video and you can try to think what exactly we can see in this X-ray. Now in this X-ray we can very clearly make out that this is an hard border. As we can see, this is all hard border, and here it is an hard border. We can very nicely make out. So this is a heart, and apart from this heart, what we can very clearly see is the very dense lines, very dense fibers like lines which are going from the center, which is the hilum. This is area is of hilum. Hilum means where the all the blood vessels to both the lungs, they go from this area to this area. Not only the blood vessels, the pulmonary artery, pulmonary veins, the bronchi, all these things actually uh, concentrate over here. So all the bronchial arteries, they go from this area to almost the periphery of the lungs. The pulmonary artery that goes to periphery to the lungs. The all the uh, respiratory tract, that trachea, main bronchus, and the subdivisions of these bronchi, they go and divide and they go up to periphery. So this is the normal structure of the this division, but usually it is very crystal clear. This is usually very crystal clear, as we can see this thing here. So this is a normal X-ray. This is not actually a normal X-ray. This is very typical X-ray of a COPD patient. But here, what we can very clearly see that this is the heart shadow, and this is the the pulmonary artery trunk. So what we actually have is the small vasculature that arise from this hilum and that go to the periphery. But we can see this hyperlucency, this blackishness is all because of the air. This is all air because the lung is very well filled with air. So these lungs are very well aerated, and there is no congestion of fluid in these lungs. That is the reason why this lung field, it appears very much radiolucent or black. But when we see the same X-ray in this field, we can see that this is so hyper white. There is increased whiteness, and see the periphery of this lung looks slightly spared compared to the area here. So this is very much hyper dense. This is very much white. So this is a very typical perihilar and bilateral lung involvement. So what we can see is there is a very typical perihilar involvement, and this very typically we call it as a bat wing appearance. So if you know a bat, which is a flying creature, so these are the two wings of the bat, and there is bilateral perihilar involvement, which exactly tells that these lungs, which should be actually radiolucent or black like this structure, they appear so much white. This white is all because of congestion of the fluid in these lungs. And this acute pulmonary edema is actually a complication of acute LVF. So acute left ventricular failure actually causes so much congestion of the LV, which actually causes so much congestion of left atrium, and this left atrium actually gets the blood flow all from the right lung as well as the left lung. So as there is so much of congestion in the left atrium, all these veins cannot actually drain the blood inside the left atrium because there is so much congestion of this blood, so-called blood or the fluid into the lungs. That is the reason why these lungs alveoli, lung interstitium is significantly filled or congested with blood, with fluids. That is the reason why lungs, if they are crystal clear, if there is no congestion of the fluid in the alveoli or in the interstitium, they will appear radiolucent. But if the interstitium, if the alveoli are there filled with water, automatically X-rays cannot pass through that portion and they automatically appear dense white or white. So when we see that there is fiber-like appearance, when there is a bat wing appearance, where there is perihilar involvement, that too bilateral peripheral, uh, that very highly suggests of acute pulmonary edema. We can see these angles are pretty clear. They are not very much blocked. And if they are blocked, they can be sign of actually chronic heart failure, because in chronic heart failure, pleural effusion can be a very common finding. The other differential diagnosis of such things are viral pneumonia. But in viral pneumonia, usually this acute pulmonary edema actually appears very fast. So most of the time, most of the patient, if they have acute myocardial infarction or any drug allergy, or if during some procedure patient suddenly deteriorates, or if the patient has anaphylaxis, or if the patient has trauma, in such conditions patient land up in acute pulmonary edema, and they always have typical bat wing, typical bilateral perihilar involvement, and there are fiber like involvement or fiber like lines can be very clearly seen from hilum towards the periphery. But whereas in ARDS we don't see this fiber like lines. In ARDS what we see is patchy and dots like or reticular shadowing. Reticulonodular shadowing will be seen in ARDS. So this will be mostly involving almost all the fields or at least four fields, and it uh, involves all the areas of lungs. It does not typically involve the perihilar involvement. If it is consolidation or pneumonia, most of the time it will only have one unilateral lung involvement. It usually won't cause this type of typical perihilar or bat wing appearance. And in effusion, any effusion, most of the time it will always first block this angle. But as we can see, the angles look okay. Those angles are not blocked. This is costophrenic angle and these are not blocked, so there is not much of a pleural effusion. So this is a very typical X-ray showing acute pulmonary edema, where there is a typical perihilar involvement, where there is typical sparing of peripheral portion of the lungs, where there is no much pleural effusion, and there is typical bat wing, typical bilateral perihilar involvement, highly suggestive of acute pulmonary edema. If it is chronic pulmonary edema, usually the patients have bilateral pleural effusion, and very commonly we can see dilated heart, which is missing here. One more thing which we can see is this is central line or a dialysis cannula put through left IGV, and this is an endotracheal tube which we can very clearly see. And that's all for now, and thank you.